Welcome everybody to BHIUT's Trust Board meeting, part one. Today, particular welcome to Louise Dark on her second day with the Trust and her first BHIUT board meeting. You're very welcome. Thank you, Louise. We've got apologies for absence from Caroline, from Alan, from Linda Vandenhender and from Helen. Declaration of interests, updates. No, we haven't had any updates reported. Has anybody got any conflicts or any updates they need to report now? We'll have Louise's for the next meeting. We've got the minutes of the previous meeting held on the 5th of January. Thank you to Maboo for chairing that in my absence. Let's just go through a page at a time in terms of the correctness of the record. So, Linda, I think we don't need to always have all of the interests in the meeting pages. As long as it's available somewhere, they don't need to be in everybody except meeting papers. Okay. So, minutes from the 5th of January. Page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, page 13, page 14, page 15. So we'll take those as a correct record. Matters arising, nothing that isn't covered elsewhere on the agenda. Has anybody else got any matters arising? Come on to the action tracker. Okay, so on the action tracker, we've got Catherine was going to update us on the reasons behind the number of complaints increasing between October and November 2022.
So have a look at this, and there doesn't seem to be specifically themes of the complaints are the same as we get most months. Overall, the number of complaints that we're having in comparison to the previous 12-month period is decreasing, so we think it probably was just a blip over that month, but we'll keep an eye on it because overall last year we had 909 and now we're at 758, so there's actually a decrease in the look, but there wasn't anything when we looked at it, so we've got a particular issue in a particular area.
Okay, thank you. We've got oh yeah, sorry, and the next two are not yet due. So don't need to do anything about them in this meeting.
Jackie, I just wondered if the second one should actually be reviewed by CLAC.
Yeah.
Because we wouldn't normally do that sort of level of detail at this meeting.
Yes.
Okay, and we'll report into the Culture Committee as well.
Yes. Okay, and then we can hear the the results as part of the feedback from the committees to this board.
Right.
Yeah. Okay, that's great. Yeah. Thank you. All right. Chair's report. So just a few things from me today. Firstly, thank you everybody for the site visits this morning. We'll have the opportunity to have some feedback from those in the part 2 board. Just a couple of things for me to update on, having done since the last time we met. I had a very good regular visit to the patient experience hub here at Queen's with the new deputy head of patient experience, Becky Denny, and chatting to the team and hearing about some of the initiatives, particularly the work that they're doing, which I think is very important, on ensuring that carers are properly recognised as part of the care team when the people they care for are admitted as patients to the hospital. And talking to one of the patient partners, Maxine, about the work that they do through the Patient Partner Programme, which, remember, is an important part of ensuring that there is a patient voice in new developments, and is an important piece of work going on there. A couple of other staff network issues. I was very pleased that members of staff here from BHIUT were able to attend the LGBTQ History Month event that was held at Barts with Peter Tatchell speaking at it. Good example. I mean, it was a great event, but it was also a good example of the way increasingly that the staff networks are working together across Barts BHIUT to make the most of not just events, but also thinking about how they can work constructively together. And that's happening to an extent again next week as well, with International Women's Day on Wednesday, when I know I'm doing a pledge, and I have recorded a video, and Mamta, I know, has recorded a video as well as part of that. So that's next Wednesday, and will be fun, I think. Some external stuff. Matthew and I attended the Outer North East London Joint Health Overview and Scrutiny Committee, where the members were particularly interested in updates and work on what we're doing to improve patient experience following the CQC inpatient survey results, which we've obviously discussed in this board. And I think we've had a good account of the considerable amount of work that's been happening to improve the way in which I think will lead to considerably improved inpatient survey results this year, or I hope would, but it's good work anyway on its own. Councillors, unsurprisingly, were also interested in hearing about the impact of strikes, cancer waits, long waits in the ED and maternity services, and the plans that we have with respect to winter pressures. So it was a good, interesting, engaged meeting, I thought. And then finally, Matthew and I have been seeking spiritual guidance, and on the 16th of January we met with the the new Bishop of Barking here at Queen's, who was invited by the chaplaincy team, very well led by Phil Wright here at BHIUT. So that was a good contact to be made. And then on the 6th of February, Matthew and I, along with Peter, visited the Gardens of Peace Muslim Cemetery, which was a very interesting visit. We saw the very good and extensive area of the cemetery and facilities that are there, and had some useful conversations about how we can continue what I think is a good relationship between us and the cemetery, and particularly the funeral directors at the cemetery, about how we can ensure correct but speedy ability for families to be able to bury their loved ones if they die in a hospital. So that's all I wanted to report on in my report. Are there any questions or comments on that before I move on to Matthew's report? Kathy?
Just a quick one. So great to hear of those interactions with community faith leaders and so on. And I know we're all got more than enough to do, but I'm just wondering whether or not there's any possibility for other members of the board perhaps to have the odd something like that, because I think I've done it in another place, and it sort of, it does help you with your thinking about how we engage with all range of different faiths.
Okay, let's have
Just a thought. I don't know.
I think I could both offer opportunities when I'm invited or Liam invited, and we could also think perhaps about how the board gets the chance to talk to the patient experience team as well about some of the engagement work that they're doing there, and that may well throw up fora in which it would be good for people to take part. Good. Matthew.
Thank you, Chair. So the report I'll take as read, just highlight a few of the points in there. There's a good piece in there about what we've been doing at King George around the accreditation of the elective surgical hub there, which is a dedicated hub for a number of 6 specialties where we offer a sort of protected environment for the provision of planned care. The NHS has a standing annual problem with cancellations across planned care because of the pressures of emergency care. And when you get sick folk coming in through the front door who need beds, who need places in wards and in critical care and so on, some of the patients who are waiting for their care do find their procedures may be postponed time and time again, which is very frustrating for everyone, not least for the surgical teams who are there ready to work. We've funded a theatre and then we can't provide the activity because we don't have beds. And what King George gives us is this dedicated facility for that, and it's really helping us pull down the size of our waiting lists. It's helping us with the immediate task of removing 78-week waiters by the end of March. I mentioned in a report that we had close to 50, it's down to 32 as of Monday. I think Fiona and Amash, who are our leads for this, could probably name them all. Now they all have dates, and we're doing everything in our power to make sure that these people get their procedures on time. And then our next target will be eliminating 52-week waits as we work our way through the backlog. And we shouldn't underestimate the fact we've got this accredited hub, or in process of accreditation, the only one of its kind in London, which is really offering us a fantastic asset. At the minute, it's been predominantly an asset for BHRET, but we've also been talking to partners across North East London, how we work with Barts, who've got the Barts Health Orthopaedic Centre, and also at Homerton, who had additional theatres funded through recent investment in elective care in North East London, to really provide a network of environments across North East London where we can make sure that our population get the care they need in the most timely fashion possible. And I think, you know, there's been a shift strategically in terms of the separation of planned care activity from emergency care activity that, given the size of the waiting list we've got, I think it has to be built in and sustained over the years ahead to get the waiting list back to where they are. But we've had Sir David Sloman visit, who's the Chief Operating Officer of the NHS, also Chris Hobson, Director of Strategy, and there's some feedback from them in the report, but I think they've really embraced what we're doing there. And the staff there are tremendously proud of what they're doing, actually. And now that Louise has joined us from London, where she was lead for the elective recovery programme in London, we look forward to that going from strength to strength, while not ignoring the fact that at King George we recognise the differential between the quality of what we do in planned care, the real challenges we have around emergency care and medical care there as well. You know, so very much focusing on it as one hospital, a real asset for the community around it. I'm looking forward to see what we can achieve with the new site leadership team in place. There's other information in my report about the CQC report, which was published a couple of months ago now, but I think it was a very fair assessment of where the trust is, a reflection of the compassion and care that our staff have been delivering in some really difficult circumstances. I think it's been interesting looking at some of the work we've done, which is starting to take effect. You know, our pre-midday discharges are up around a third on where they were a year ago. Our type 1 performance at Queen's was actually 10%. It was close to 12-13% higher in January than it was a year before as well. You know, so some of the activity we've done at Queen's is starting to show benefits, but there's still a long way to go. And actually, we still know that the quality of the care we provide in the emergency department, the patient experience there is not where we want it to be. And it'll be, I think, a common theme this year throughout the board on what we're doing on both sides to try to get that into a better place. Recognising that what happens in the emergency department is predominantly a reflection of poor flow through the medical health pathway right through the hospital. And while I have talked before about the challenges we face in terms of mental health patients, primary care, community care, lots of this is within our control. Lots of this is within our gift to get right. So there's very much a focus within the leadership team and the trust on how we take responsibility for that and get that right, while also working with our partners on those really important external dimensions that sometimes make the job harder than it should be. I should say there has been notable increases in acuity, and particularly over the winter period. I know nationally, the ONS figures around mortality in January showed a really profound spike, actually, and we saw that within our hospital, and that was seen broadly in hospitals across London. I think one of our weeks in January was the highest rate of in-hospital mortality here outside the pandemic. I think that pattern's been reported nationally as well. Some of it's COVID, some of it's flu. Lots of it is older patients with lots of things wrong with them who've been exposed to seasonal illnesses. So in the context of what we're doing around the emergency pathway and the extra investment we've put in, we are dealing with a patient group where we have seen this increase in illness. And one other real positive thing I think around the emergency department has been the expansion of the REACH programme as well, which has been run at Barts at the Royal London for the last couple of years. This is where an emergency medicine physician talks to an ambulance crew who decided to bring someone into hospital and sees if they can offer advice that avoids that patient coming into hospital. We've now extended that as from January to cover King George and Queen's Hospital We're building it up at the minute to try to get an understanding of how much benefit it can provide. We think there's a potential there for us to significantly reduce the number of ambulances we brought into the hospital. What we saw through the strike, the ambulance strikes, was a marked drop off in the number of over 75 patients brought to the hospitals. And what's interesting is we also saw a real increase in the number of those patients who attended, who were admitted. So the people that weren't turning up were people who might have been brought in before, but then not admitted, treated in ED and sent home. So we think there's learning from that about senior clinical decision making and the ability to care, particularly for over 75 patients in the community, rather than bringing them in and exposing them to an emergency department environment. And REACH will be a really important thing to help us with that. And I think probably the other major thing to talk about is I mentioned the ambulance strike. We've got the junior doctor strike coming up in 2 weeks' time. I think of all the strikes we've experienced so far, our trust hasn't been part of things like the nurses' strike, etc. so far. But this will have the most profound effect on our ability to provide services of any of the industrial action that's happened so far. The last junior doctor strike was a 24-hour one, and there's a difference between catering with the impact of the loss of these doctors for 1 day and doing it over a 3-day period. We call them junior doctors, but some of them are very experienced members of the medical workforce and often are the real workhorses of providing day-to-day care on the ward, also outside the hospital, primary care, community care as well. And I think we shouldn't underestimate this. This isn't all about newly qualified doctors in the first and second year training. This is a really significant part of our medical workforce who will be on site for 3 days. So we're working through at the minute, how do we deploy our consultant workforce and work with our other clinical specialties to maintain as many services as safely as possible over that 72-hour period. We will have to step down some outpatient appointments, some planned care, including elective care and diagnostic care, will have to be reduced while we redeploy people and to make sure we can provide safe services. And we're just working through the impact of that at the minute. We've spent quite a bit of time as a leadership team talking to some of our junior doctors and their representatives recently. I think what they have seen is a really significant real terms decrease in their pay. And it's interesting talking to some of them who are sitting on top of 100,000 plus of debt from their training period and are seeing most of their salary going on rental costs for rented flats and travel to get to work. And actually off the back of this really significant training period, they're facing some really tough economic circumstances, and I've got considerable sympathy for the decision to take strike action. And what we'll try to do is work as well as we can to maintain services through this period, but we shouldn't underestimate the impact of this, not just during the 72 hours of the strike, but also the fact that we'll have to change work patterns prior to the strike to redeploy people on those 3 days. And then people who've worked, who've been on site, residents cover overnight, will then need time off afterwards to recover. So I think the total impact on our services will probably span around 2 weeks. And there'll be a financial cost for paying consultants to cover the shifts and also to reschedule the activity we've lost as well. So in the context of things like 78-week and 52-week weight recovery, there will be impacts. There'll be impacts on diagnostic pathways and on emergency care. So we'll working hard ourselves. We're also talking to Barts and Homerton about how we manage this across North East London and London Ambulance about how we maintain safety through this. But that's going to be an impact. And then we've got Easter, then we've got Eid, and then we've got May with extra bank holidays. So we have got quite a choppy couple of months ahead in terms of workforce sustainability and so on. So there's a lot of planning focus going on in that context. And this is the time of year when the NHS does its planning. Between now and May and June is when we're thinking about winter, how do we get fit for that as well. So we've got we're balancing these things out as best we can. So a lively time, lots going on, lots of work to do, and we look forward to keeping the board updated on the impacts of this strike and any other action that materialises over the weeks and months.
Thank you, Matthew. Mark.
Just a couple of things. So, Matthew, I think your point about the debt that these people are bearing. So we've just given out £92,000 in hardship grants. The median student debt amongst those that applied was 78,000. The highest student debt, meaning this is in year 5 of the course, was £137,000. So they're going with enormous debt, partly because they get reduced support in years 4 and 5 of their training programme. But then carrying that forward, that burden of debt is really massive. And I think that we, to try and help during the 3-day strike, we've withdrawn all our clinical students from all acute placements and we'll provide alternative teaching to release consultants and other time to focus on the coalface. So all the students are gone on those 3 days. they're back at Whitechapel doing other activities, and so there won't be a detriment to the tuition, but it won't be delivered in the placements in BHRUT or Barts Health Hospitals.
Any other questions or comments on Matthew's report? So,
Thank you. Matthew, you talked about the phenomenal work that our surgical team are doing around reducing the backlog, but we also know that the higher proportion of our waiting list is outpatients, and clearly it's the same teams working with the same lists. I wonder if you could just talk a little bit about how we're going to tackle the outpatient part of that equation.
Certainly, I think when we talk about waiting lists, we typically think of someone who's at home waiting for surgery, but actually around 2/3 of our longest waiters are people who are waiting for an outpatient appointment. We took a hit, was it 30 plus outpatient rooms we've lost here?
30 rooms.
Because of changes to the configuration of the hospitals over the last couple of years. So the way the urgent treatment centre is now used to be predominantly outpatients and so on. So we have got a real challenge around physical capacity for outpatients. We're trying to deal with some of that by we can do much more virtually these days, so we are trying to use other avenues for that. But as part of the estates developments that are happening on the two sites and around the sites, actually, because outpatient doesn't have to happen in an acute context, we're looking at other ways we can provide these services without the reliance on the in-hospital space. We're also working with clinical teams, and we've seen some really good results recently. Actually, if you look at the shape of our PTL, so that's our waiting list. So if you look at the shape of our waiting list over the last couple of months, the biggest gains we've been made are in people who've been waiting for non-admitted procedures, so people who haven't come into hospital and for an admission, they've come in for an outpatient appointment or elsewhere. And it's about getting that balance right between the same staff who are assessing the patients about their need for an operation or a procedure versus the ones who then provide that procedure. So when we think about the waiting list, it's both chunked up between procedures and assessing people for procedures. It's also chunked up between surgery and other pathways. And actually, we're at the point where people waiting for surgery is it's slightly more than half, but it's by no means the whole of the waiting list. There's people waiting for appointments in women and children's health and in all kinds of medical specialties as well. So I think the concept that the waiting list is a surgical waiting list is one that I think holds the public mind, but it's actually a much more complicated moving piece than that. We're making sure through the work we do that we're focusing on all those areas, and the real gains we're making at the minute actually are around non-admitted patients.
That's really helpful, thank you.
We would like more outpatients.
I was waiting for that.
I thought maybe I wouldn't say it this time.
good. Okay, thank you. Thank you. Collaboration update, Shane.
Thanks, Jackie. So you've got a good summary pack, some kind of helpful context up front about integrated care systems and how those are there to arrange services around patients, not around organisational boundaries. And I think the acute provider collaboration further extends that to say how can we work together to better patient and services. So we're working extremely well between Barts and BHRUT, but also with the Homerton as the three main acute providers in East London. You can see the number of work streams in the pack. So we talked about planned care, UEC, quick care, cancer, maternity, and babies, children, and young people. And each of these work streams now well established with the hospital chief executive leading that resource. There's a human resource allocated to help those. And then very recently, a helpful discussion on how we might get some shared clinical leadership right across North East London for these various work streams, and that will be across all three trusts. And that's quite a powerful enabler to how we might make many improvements by working together. In terms of early successes, Matthew's referenced the REACH model being rolled out across to the HRT. That's great. I think Matthew and I now want to see how we can drive those numbers up, because actually there's probably lots of room there to see lots of more patients and make a big impact here. Departments. And Nick is already doing some great work with his counterpart at Barts around sort of like corporate services where we can get maximum value for our money together. So I think we've been said many times that the two trusts will remain separate statutory bodies, but very much wanted to move within that context to a group model where we have 7 hospitals working together whilst respecting their sovereignty organisations. So the next steps really are to take the various work streams forward. Matthew and I are also quite keen that we avoid any duplication between what the Barts VHRT collaboration is doing with the acute provider collaborative, and increasingly we can see obvious ways we can bring those work streams together to have that focus right across the patch. So happy taking questions, Chair.
Thank you, Jane. Ruth?
My question about the collaboration is, how far does it extend? So at the moment from primary care, some hospitals are ring fencing certain services. So for example, I can't refer to Homerton for neurology because they say our patients are out of area, and yet Homerton area of patients can refer into VHIT without restriction. I just think if we're working towards this collaboration, there needs to be that fluid agreement that patient, and there should be this drive for patient choice. If that's not there, my worry is how that's then viewed by patients and staff alike if it's not a true collaboration of all services.
Pia, do you want to respond to that? Pia?
I'm very happy
Yeah,
to. Yeah. So, well, from a practical perspective, referral restrictions were implemented just during the pandemic and just before. I think what was evident was that it wasn't patient choice. It was just that services were being used for lower waiting times. So essentially patients were just following lower waiting times around the system. And what that was really doing was collapsing the resilience of some services in some areas. So just because the waiting time's short, it doesn't mean the service is resilient. You might only have 2 consultants. So the first iteration of referral restrictions was an attempt to smooth out demand across the patch and to stop some services, particularly at the Royal London, actually, from being kind of, excuse the language, but bombarded with a lot of referrals that they couldn't cope with. So waiting times going up and up and up, and then what would happen was they just moved to the next service and do the same thing. So it was the initial plan was for smoothing, and so the Royal London and Homerton did the same. And then what actually happened, and I'll take full responsibility for this, I came here and noticed that the only hospital that didn't have any referral restrictions was BHRUT, which might explain why the waiting list was 65,500 PT pathways. So what we agreed was that rather than take everyone's referral restrictions away and just let it be sort of back to a level playing field in terms of access, that we would put reasonable restrictions in that prevented out of borough referrals going to different hospitals. So sort of levelling the playing field, but in a slightly different way. So, for example, we have a commitment to serving patients from Essex. We always have had. It's a historical arrangement. So we didn't turn off referral restrictions, but we did reduce referrals from some of the inner East London, North East London GP practices as they were bypassing Whipps Cross and coming straight to Romford. So there's a reason why it's there. The plan through the Planned Care Board, though, is to get us to a point where we have recovered from the pandemic insofar as we've had long enough to deal with some of the legacy backlogs, the really long waiting areas, and then at a point to be agreed, all take away referral restrictions at the same time to create a much more mixed economy of patient choice and venue being, up to GPs and patients to agree between them. So there is a direction of travel, but we're cautiously looking at it because, for example, if we just fill another service full of lots of out-of-area referrals, we will never recover as a system. We will just cope with different levels of recovery.
Shane.
So this is a great example of behaviours that are entirely understandable and have happened because of the way organisations are configured around organisations, not around whole pathways. So everything described is absolutely fine.
Yeah.
But you step right back from a patient perspective, it doesn't make any sense at all. So this is exactly the sort of stuff we want to pick through having this combined boards leadership across North East London. And one of the key things, of course, is that if Matthew is just accountable for the waiting list at VHIT, and I am for Barts, and someone else is at Hobbs, is it any surprise? And that's how we judge externally. Any surprise that their behaviours, those organisations are, well, they make sure I don't get too much work. Whereas actually, if we take that away and say at an APC, the acute provider coverage level, we're responsible for this pathway or this special, whatever it is, it's going to shift things around quite a bit. It will take some risk there for us collectively doing this together, but that's what the appetite we've got. So I'm hoping in a year's time you can sit here and say, actually, that pathway looks significantly different. Patients have got much more choice across there, and we're not too worried about it being longer over here and less over here because we've sort of managed this together. Now, it's quite a step from where we are today to get there, but that's the sort of vision. That's what we're trying to head to. That's probably even go on to how do those pathways connect with primary care and everything else. This is just about how the hospital works.
So I think then to reply to that, there's a piece of work of communicating that to partners, because I don't think that's been understood in primary care. And it's also definitely not understood on the booking system that doesn't actually talk about any of those restrictions. So I can actually choose Homerton still, and then it's only when they go through their triage process that they get declined, and sometimes that could be 2 months down the line. And then I'm having to restart a patient onto a new pathway with a 2-month delay, whereas that could be all inbuilt into the system.
So the plan care group will pick this up, but the first thing is to agree what are we actually doing, where are we trying to get to. The mechanics of this, how it sits in the choosing book system and everything else, will be how it actually makes a difference to GPs and patients individually.
Yeah.
Kathy.
Yes, so thank you for this. And I think that my sense is that actually we're in a fairly advanced state on a provider collaborative, and it's great to see the specific things that we've got. And it's good to see the number of things that we're showing benefit. But I just wonder, in the spirit of being transparent through a board and so on, as to whether or not that maybe it's in development, there are some more what I call systematic things, the benefit of actually doing it together that could be reported on a more regular basis. We should expect to be kind of tracking as a board. But I say that in the spirit of I do think this is quite well advanced, and there's many provider collaboratives that are not at this stage where they can say these are the things we're actually doing, and here are some of the early benefits. So, but it'd be great to know that we were going to get some real tracking, so that we're not just kind of doing it somewhere else. It's actually visible. I think I find that really helpful.
I think that's a very fair point, and we are now, as we know, in the collaboration committee at the point of having both identified the priorities and identified the key actions. And perhaps the next task is what would be the key measures, which could then, as you say, form part of the collaboration report to both of the boards.
Yeah, and from an APC perspective, in parallel to Homerton as well. I totally agree with that.
Sorry, Anne.
Yes, I was going to pick up on Fiona's point to Ruth's question, but actually it may respond to your point as well. So two for one. So just completely support that cautious and planned approach that Fiona's leading with other colleagues across the acute provider collaborative around that point of patient access, referrals, etc. Because if we do just kind of release everything and release all the restrictions, then we may well have a problem, create a problem in terms of incontinence. Because those patients who can move to where the services are open or to where a waiting list is short will do that, but that's not necessarily all of the community. So we may well be underserving some of our more deprived communities. So therefore, all of that work will also be supported by the emerging clinical strategy that comes out of the acute provider collaborative. And that may well be part of the work that you may be interested in, Kathy, which is that kind of systemic measures of the longer term impact that we're actually having in collaboration.
Right, let's move on then. Quality Assurance Committee report.
Yes, thank you. Just to say, as you can see, there's quite a long report, so there isn't a lot I need to add. I think you'd be relieved to know. And just to say that Linda and I are in discussion about how we can make this a bit tighter. If so that's just a state of things. So as I say, I'm happy to take questions. Like we've covered an awful lot of areas, and you'll note we did a deep dive as well in a thorough deep dive into that areas, and obviously maternity was a significant point, which again we've discussed here plenty of time. So wasn't going to say any more than that because if you have read it, there is plenty of it there.
Okay, thank you. There is because there's a lot of good work going on the committee, so thank you to you and to the committee for that. Are there any questions on that we're not picking up later on? No, okay, good. Integrated quality and safety report then. Catherine?
Thank you. A number of points I was going to raise have already been covered. So I was going to talk about patient experience, but Jackie's already talked about the work that we're doing there. But I would like to say that this week we had our first patient panel. Matthew had asked that we meet with some patients to hear their stories and to do that in conjunction with clinical teams. So we did that as our first trial on Monday. Had 3 patients that came in. Actually, it was 3 mothers that came to talk about their experience of bringing their 3 boys into the organisation. It was really good. They told really sensible stories. They highlighted where we were good. They highlighted where we weren't so good. And really the major challenges that they talked about were things like communication. You know, some communication was really good and some communication was not quite so good. We wanted to do it in that way so that the clinicians could hear what patients were saying, not only exclusively through the complaints process, so learning. We felt that it went well, and I think that the people who contributed felt that it was very helpful. The people that sat and listened felt that it was really helpful and are going away to think about how they might be able to do some work. We've also committed to those 3 individuals that we will ask them back to tell them what we've done about some of the things that they raised. Some of them are relatively quick fixes. You'll be unsurprised to know that on the children's ward they found Wi-Fi a real problem. And I know we've just done our walkabout where if on care of the elderly, Wi-Fi was a problem, so it reaches across the generations. So we do need to really think about that, I think, because in terms of our patients, there's really nicely written on one of the quality walls on the wall. It is very boring here, and that is so it was a new thing to do. As I say, Matthew has asked us to do it. It worked really well, and we're planning to do it more regularly. We learnt that we needed far more time than we had, so we'll change it and we'll develop it as we go along. But I think probably in a few months' time we'll bring the report back here to talk about the impact of that, because that's Matthew's already talked about CQC reports, so I won't do that. And the other thing that I just wanted to raise, particularly through this report, is we're moving ever closer to PSAP and the introduction of PSAP. So we're focusing really hard on getting as many of the SI incidents closed down as possible, because we will have to transfer them to the new system. So we're doing a very focused piece of work on that to see how low we can get that figure down to. So I'm happy to take it.
I've got a question. A comment and a question. First of all, I know we're doing the annual infection prevention and control report in a moment, but I just wanted to sort of note that there were no MRSA cases in January. There were 3 C. diff infections, but given the length of time that I've been chairing boards, sometimes when progress is slow and there's been something in the middle, you sort of forget quite how far you've come. So when I started chairing an NHS board, the idea that you would have a month in which there were no MRSA infections would have been sort of beyond hope. So there's obviously been phenomenal change and improvement in the way in which we deal with infection control. And I think, you know, we should just note that and congratulate, I suspect, the nursing and domestic staff for the work that has gone into achieving that. So thank you. And then on the noise at night project, I'm just interested in the idea that we have to have an electronic sound ear recording device to tell us that there's noise at night. Because if patients say there's noise at night, can't we just accept there's noise at night and try and solve it?
We do absolutely accept it. But have you seen Wilson?
No.
Yeah, okay, so it's like a little board on the wall, and it's got an ear that goes from green down to red when it's noisy.
Oh, I see.
So it's visual, which is quite helpful for the staff. I think quite a lot of the noise at night is because people are chatting. So patients complain about the other patients. We can do very little about the other patients. So if we have patients with dementia, or if we have machines going off, there's very little that we can do about that really. But there is something that we can do about the general noise in the room. So we do that. It's worked particularly well in the neonatal unit actually. So we've had it in some of our trial areas. And we have been able to do things about muffling the sound for babies, because we know that a lot of sound for babies is quite damaging for them. So I think it's sometimes people don't know how low the sound has to be before it becomes difficult, and this ear just reminds people.
Okay, I can see the point. That sounds like a good idea. A sort of warning to shut up. Perhaps we can have one in. Are there other questions or comments on the air quality and safety report? Caroline?
I had a question around the training aspect. There's the training, and I want to go because often, certainly my team about, oh, this has been launched, this has been implemented. How's the attendance been? What's the feedback? What changes have been made it to work? Really, they were over 90% of the whole, which is a good thing. What we've recognised over the last year is work on specific areas of training. So we have foundation training that everybody has to do, and the work they're doing is unique particular area of work. That works on, so we're starting to build on it. There have been a few things that people now want in that you have to go to ask for your mandate. Go through that, it's being assessed, because we don't want to have done all this work, got down to 11 and gradually over the next. So I think having that committee, and I think we'll build that we need.
Are you drawing any conclusions, when the training has happened? Are there improvements in areas of performance, things like that? Are there things that you can out really just?
I think that's a really good question. I think that fire safety training there. But if you look at resus training, got quite a lot of right, and so we've got a resus team. Really difficult to say that having that mandatory training, identifying people that need to do things like resus training, has had an impact on the outcome. There are so many other elements of work. So I'm not sure whether we say that there is a direct correlation to experience change training. I think what we could say is why people are having the right training. For example, when we had our last CTC, they talked a lot about safeguarding the team. They were able to answer the questions, they were able to demonstrate how they use it. We did a lot of work on cleansing, who would do which element.
I think that post-implementation measurement, even if it's doing a few samplings like that, who understands these things, I think that's a really good way of measuring it. And often with these things, as I know from your experience, you'll be asked to say, well, what difference did it make, and justify certain things. And having that data in at the start makes things a lot easier.
Thank you very much, Caroline.
Good. Any other questions or comments? Okay, thank you. So the annual report into infection prevention and control. Are you presenting that?
I thought Sean was going to join us, but I'm happy
bit
to.
early.
Yeah,
Is
that's
that
all right. I could talk through it. So we've actually had quite a good year with things from infection prevention. I was hoping Sean could have heard the feedback. So we've done some focus work around MRSA actually, particularly on the surgical wards, and I think we're seeing the effects of doing that, or the success of doing that. So the main highlights is we continue to struggle with C. diff infection, which is related to the use of antibiotics, and there is a direct correlation with not having an electronic system to do antibiotic monitoring, and we're trying to get our antimicrobial pharmacists to do some focus training with our clinical leads around that and to implement this. So, just having some processes around timed prescriptions and work through that. So that's a work in progress, and we're quite. I'm hoping that as EPMA comes in, it will be a lot easier. But till then, we need to do the manpower conversation with everybody, including the juniors,
around how long we give antibiotics. MRSA is better. COVID-19 is also better, but we're yet having sporadic, wards with bays where patients with COVID-19 are here. Patients are here. So the key priorities again for 2023 will be around C. diff. We have a plan. Next help. We had a helpful conversation around pharmacy, presence of pharmacy on wards, and how we're going to continue to monitor that. We're going to also look at the implementation of the ward-based electronic system for infection control, so that with the help of the new software we have launched, which is called
It's Megan, I see it.
Okay, yeah.
So the Meg does the audit, I see it.
And what it then does is the communication between the microbiologist with the ward-based teams a lot easier, and there is governance around advice given, and you don't have repeated calls around that. So I think that's working quite well. The other thing we need to do is looking at our surgical site infections. There's an excellent project led by an obstetrician here that's been shortlisted for an HSJ award in a couple of weeks around surgical site infections, particularly with obstetricians. But we need to roll that out across all of our surgical divisions, and looking at the vascular, so line-related infections. So I'm happy to take any questions in addition. Thank you.
Kathy.
Yeah, so obviously a huge amount of work and great progress. And the C. diff is a challenge, but just going to the audits, you sort of touched on the benefits that will come from an electronic world. And I suspect that the audits are a bit sporadic and because of the nature of the burden of them, etc. And so trying to ensure we've got a really good picture of actually what's going on. I just wondered about your degree of confidence in that. It will obviously presumably rise when you get the electronic world, but it just worries me a little bit when we get a picture of really good stuff happening. How does it triangulate with everything so that we actually have a totality? And are we missing something because we can't do as many audits, which take up time, don't they? And are we basing it on accurate information? I would think I think you're right. It is difficult. We're making the best of what we can do. So there's the whole piece of work around: are we treating our patients with suspected sepsis on time? So not correlating the news with the timing of antibiotics. So I'm working with the improvement team to actually get assurance. We've looked at ED particularly. Then once we prescribe antibiotics, I think the biggest bugbear or the biggest challenge is to review IV antibiotics in 48 hours. So we tend to have IV antibiotics given for a prolonged period of time. So to have a stop function to say at 48 hours, every patient on an IV antibiotic, not in addition to medication errors, the fact that these patients don't necessarily need to be on IV. And the fact that that's all good, but I suppose just to cut through, we've got a bit here in the reports telling us that the 2021 audit was in October. So it's like an audit once a year, whereas presumably if we had electronic, we'd have a continuous monitoring of where we would be, which would give us a better picture of, did we pick a particularly good or a bad month? I don't know, just by chance. Have we got all the information? I know there's nothing we can do about it, but I'm just bringing in a little bit of scepticism about are we getting the full picture is all I think.
Is that a response to this, Catherine?
Yes,
Yeah.
So we've had the MEG system, which is an electronic system, but we've only had it in for about 6 or 8 months. Prior to that, all of our audits were done on bits of paper. So that was really difficult. So the team have done a lot of work around cleansing which audits we should be doing and how we can do it on the electronic system. So I think going forward, we would have much more confidence in the audits that we're doing because we've got that audit trail about when they're being done, where they're being done, and how frequently. And then as a result of the results of those audits, we can then target our work going forward, which is a real problem that we've had before. And I would just like to say, ICNet has been a labour of love to get in. It has taken us years and years. Most people use ICNet to monitor their system, their infection control across organisations. We haven't had that, and that will make an enormous team, and that has taken it's in now, and it's working now. We managed the whole of COVID and all of our infections on PC and Excel. I don't think we were alone in that, but that was really difficult. When I got the electronic system in, it will release a lot of time from the infection control nurses in particular to support the work that we need to do on the So I think this year has been quite a change for that team in terms of moving from the highly paper-based obviously, to a much more electronic system, which should give us those more robust results that you talked about, and also an ability to track where we need to go.
So one was a comment, kind of goes on from the electronic system. So community, we've had electronic for years and years and years, and joy of it is an audit is continuous. It never ever stops. And the power that we're going to have of linking our community data to the secondary care data could really put us in a good place for our patients, because it's not actually just about what's given here, it's sometimes about what they've already been given in the community, and that knowledge is lost as soon as they come into the hospital. One thing I was going to mention from the report is I was actually quite surprised that only 34% of our patients were on antibiotics at that point of time. And actually that probably worries me quite a bit about how many people are just sitting here waiting for discharge, because I would expect it to be much higher in an acute hospital. And the only thing I was going to mention about COVID is, are we seeing kind of incidental COVID, as in they're swabbed and picked up for COVID, but we're not seeing that they're particularly affected by COVID, or are we seeing ill patients COVID? Do you see what I mean? Because of the COVID.
Yeah. I think we went through a phase of incidental, then through winter we had affected,
Right.
and I think we're going back towards incidental again. So the numbers of patients admitted for COVID are reducing, but we are yet seeing COVID infections which are incidental. So we went through a phase, I would think, in December, was this the third week of December, probably, but a week in December, we saw a lot of positive patients coming, which meant a lot of our infection control across the hospital needed to change, or the patients needed to move from bay to wards and stuff. But I think we're now seeing incidental.
One of the, just following up that, and the point about how many people are sitting in the hospital well and not able to go home. One of the very interesting things that Sue and I heard on our visit this morning, which was to the sort of frailty and elderly services, was first of all the quite worrying, shocking really, suggestion that quite often elderly people get COVID because their relatives, who understandably want to visit them, actually come in with COVID and give it to their relatives in hospital. So I suppose just a plea that we probably just need to keep reiterating as we rightly open up after the pandemic, that if you are ill and have symptoms, please don't come and see your elderly relative in hospital, because you may well make them even iller. And actually, even if you don't make them ill and you just give them COVID, one of the other things we learned was, rather topically this week, that if you are an elderly person and you are otherwise well and in fact asymptomatic, but you have a positive COVID test, you then have to wait 10 days before you can be discharged from hospital into a care home. So that's 10 days sitting in one of our beds, largely well, because of the prior COVID positive tests. So just something sort of linking the experience this morning to this. Are there any other questions or comments on the infection prevention control report? Okay, thank you. People and culture report from the committee, Leslie.
So not much to say. We talked about the organisational redesign, and as you said earlier, it's really good to see Louise here as part of that redesign. And I think the committee was pleased that the organisational redesign was focusing on how people do things as well as what they do, and therefore there's a real focus on recruiting for people's leadership skills rather than just their technical skills. So what we are doing is actually we will begin to create an extended leadership group that will be able to lead the culture change in the organisation. So I think we felt that was something that was really positive, and we were very pleased to see that. We talked about the HE visit and plan, and I know there's part 2 report on that, so I won't say anything more about that. We also had a bit of a discussion about turnover, which Kathy picked up, is picked up in Kathy's written report as well. Although it's stable, it is high, and particularly in some areas. And we're going to be looking at recruitment and retention plans in areas which have the highest turnover, because that's impacting on temporary staff, and therefore that's impacting on bottom line in terms of budget, and impacting on quality of patient care too. So we'll pick up some of those areas which particularly have high turnover, and there'll be reports about, and that's ED, critical care and frailty, and I will make sure there's liaison between the two committees.
Thank you. Any questions on that? Okay, finance and operational performance report from the committee. Abu?
Thank you. Just, I assume the report's read, and I'll just briefly mention a few things, and then there's others that will be picked up during the course of this afternoon in private session and elsewhere. So we will receive a monthly update on HE finance because of the significant importance that the board put to this matter at our last board meeting. So we received the first update, which is on the private board agenda, so I won't say more to that. The end of year position looks likely we're going to hit that 15 million deficit. Use of some non-recurrent funding, but for next year, because of the dropout of COVID funding, the scale of challenge for all acute trusts, but significantly for us, is going to be much steeper than this year. So there's bottom-up, top-down plans being prepared, and the organisational structure, and also there's a focus collectively by execs on money. It's been really helpful and puts us in a good position. And this morning, whilst you fantastic folks, able-bodied folks were around doing ward walks, I was in a room with a colleague who just started here, a consultant who's setting up the PMO. So I'm really pleased that Matthew and colleagues, Nick and others, have got someone in, because it's really important to have that sort of corporate oversight on our major programs and keeping them to on track. And as part of that, there's some of the significant savings. The committee in the next couple of rounds are going to have the PIDs and the scoping document for those savings to have that sort of look at assurance on that. The cash position is interesting. We'll be heading into the next year with some risks around cash, and Mike will talk about it in his report. But the system as a whole has got cash in parts of the system. It's just that we want to make sure that we've got that collaboration at system level to make sure that everyone's got the cash that they need. With a discussion around PELC and our front door, and Matthew and I, as part of our catch up on Friday, spent quite a bit of time about the front door and the system conversations around PELC, and perhaps Matthew might want to talk about that in private session. And then there's the continued challenge, which then relates back to against another system issue about mental health patients and where they are with it. It's a challenge, that the risk I want to put on the board is aware of it, but just want to underline and emphasise it at this
meeting. Any questions or comments on that? I wonder, Nick and Mabu, when we at the board will look at and consider the financial planning for next year.
So we've been having discussions at committee level and what those are, and we've had discussion this morning, yesterday, around if I can start by saying that the cost of floor being stuff is a significant amount of money, and that's where we want to try and bring the board into sight of that next month, and it will give an idea of which particular pathways we're talking about, and whether the board can reach a view on how much value that investment that we've got, which is it adding to patient outcomes and the cost of wastage in the system? Because we could, if we get at that and we bring people into sight on that, that'd be a good starting point about discussing next year's plan.
Okay.
Yeah.
So that includes next year's overall next year's financial plan,
Yes.
budget,
Yeah.
view of where financially will be by the end of next year.
Yes, where we want to be at the end of next year. The thing is that the money stops at the end of this financial sort of cut off on the 1st of April. The additional COVID funding drops from 26 million to 6 million. So we're going to have to run really hard, so the run rates can be really strong next year to try and make sure we get the savings out. But I mean, Nick and colleagues have been doing a lot of work on the details, which we'll bring forward next month. Nick, do you want?
Yes, certainly. So next month we'll have more detail. So we've had the top-down aspiration, which the board approved last meeting, and that was to end up with a loss of around 20 million.
Right.
So
Yes, you're right.
we're
Sorry,
now,
but I wasn't here.
but no, there's a lot of work with a lot of distraction for each of the clinical groups to say, how are your bottom plans matching that? Some are pretty close. Elective, women's and children, not bad. The biggest challenge is the non-elective pathway, which, as Mahbub says, where we've put a lot of the investment. So when we'll catch up with Hard Over Barts on Monday as well to try and go with them. So a lot of work over the next few weeks, all coming together in time for next week.
Okay, good, thank you. Integrated performance report.
I was just thinking, yes,
You doing it?
I'll pick up both, yeah. Interesting, we're talking about UEC and here we are with the performance report, and flow, you know, is reflected in all of the metrics around UEC. So the ambulance handovers is the first bit of flow that we really need to improve onward to corridor care. And I had the fortune actually to spend the day yesterday with the site leadership team. I stayed at Queen's yesterday, so we're concerned about the ED performance and really sort of lived and breathed it for a whole day. You know, how do we manage each bit of flow within the organisation? And I have to say, we've got a really good group of really dedicated, hardworking individuals working on all of the aspects of flow within the UEC pathways. But fundamentally, we are creating and continue to have delays at every bit of the process. So front door, ambulance, UEC. Within ED, we need to create better flow around moving patients through the diagnostic and investigative processes and making a clinical decision. Corridor care is a result of essentially not having flow in ED, and then discharges later in the day, which contribute to delays getting into beds. So what I'm really saying, I'm not painting a negative picture at all, but I am actually painting a picture that the stats tell us the story we already know, which is that we've got lots and lots of work to do around improving each of those areas. Flow out of the hospital is a major issue, particularly in this area. And as you said earlier, if patients have to wait 10 days in a bed to go anywhere after having COVID, then essentially we've got an amount of patients that we can't move regardless of how improved our systems and processes will be. And I think, you know, the new leadership team that are coming in, and we've got a new, the nurse director for the site starts on Monday, Beth Williams. Scott Chandler's really finding his feet as the site director of operations, and the advert's out for the site medical director as we speak. So, you know, I feel very confident that despite, you know, really quite poor performance, and we know the stats don't show us in a particularly good light. I think understanding the problems properly and designing the solutions with the right team, with the right experience and knowledge will stand us in good stead. I do want to mention briefly the mental health patients. I know we talk about it a lot. We've got loads of stats about how long they're in the department and how many patients attend. The average length of stay is still much longer than we want it to be, and so we need to continue to work with our with our network partners around how we make those pathways more patient friendly and better in terms of how we receive, assess and treat patients with a mental health attendance reason. And then finally on UEC, getting better at same day emergency care, moving away from, you know, what can be easier actually is to assess and admit a patient to a bed, albeit with a long delay, actually front loading care at the beginning of a patient's attendance, getting through the, you know, the assessment, the decision and the clinical treatment requirement quicker is better for patients, creates less of a, you know, delay and a logjam within the organisation, and also gives us the flow that we need for the rest of the beds. So I will just jump straight into elective if that's all right. I mean, we could, you know, I could talk forever about elective. I'll try not to. I'll try not to. Okay. So really a static position on the waiting list. Okay, with hovering around 61,000 pathways, with some considerable improvement in long waiters, down to 1,300. We're down to about 30 patients over 78 weeks. Of course, you would imagine they are the most complex patients with delays that are related to real issues and concerns, either about their condition or about how we treat them. So biggest risks to 78-week performance are, well, service-wise will be gynae and neurosurgery, mainly to do with spine operations, not to do with neurosurgery. The junior doctor strike will and has the potential to unpick everybody's year-end plans for 78-week compliance, and that's the end of it. And it is what it is. We will work very hard to protect and support ongoing elective care and planned care, and particularly high priority cancers and, you know, cancer assessments. But fundamentally, when it comes down to it, we'll have to make sort of pragmatic decisions about what we do and what we don't. So that's work in progress, but we're all in the same boat. All organisations across the country are doing the same thing at the moment. A premise is that we're not cancelling anything until we get a little bit nearer the strike, and then we make those decisions. And just to follow on something that was mentioned earlier about outpatients, and you know, sort of 56,000 of those pathways, Sue, are non-admitted. They're outpatients. The way forward for outpatients, apart from me definitely wanting to have some more outpatient rooms for people to work in, is outpatient transformation, is changing the way we deliver care for patients by offering them to follow themselves, you know, that self-organised follow-up, lots of other alternative ways of seeing patients, either through virtual, and offering guidance and advice to GPs rather than receiving referrals. So all of that work's underway, and I hope that will start showing people the benefits of how we're going to deliver a better, shorter waiting time for all our patients. Essentially, theatre utilisation and is doing really well. Our fallow sessions are right down there now, with relatively low, the equivalent of less than a whole theatre every day in a month. Now that actually still sounds quite a lot, but all our theatres are not the same. So, you know, if the eyes theatre goes down, it's only used for eyes, and that's the end of it. So we're doing extremely well, and that's, you know, really down to the team there for doing some fantastic work. Touch briefly on DMO1, so diagnostics, we are compliant for the first time, certainly since I've been here. And that means we really are compliant. We are about 95.5%. The target is 95. So we're really out the woods in terms of access to scanning, and not out of the woods in terms of reporting of radiology, which you all know from various committees where we talk about that. But the direction of travel is positive. The improvements are demonstrating real benefits to that department and how we're running it and the performance related to that. And then the final area just to touch on is cancer. Remains obviously a priority for all of us. 2-week wait performance has dipped a little bit recently, but we're on the case with regard to bookings, trying to protect them from strikes and all sorts of other things, overbooking where necessary to remain compliant. Biggest risk in cancer is and continues to be histopathology reporting, which Nick knows I mention quite a lot when we're talking about financial planning. The Cancer Network are fully supportive of us and recognise the need for right sizing that service in support of all the work we do. Thank you.
Thank you, Fiona. Kathy.
Yeah, thank you. I'll start with the really positive. I think the story on the elective is an excellent one and stands up well, against other organisations. I think that we're so near in touching to the 78, and we've got an ambitious plan for 52 weeks, etc. And getting back on track with DMO one, I think, has not been easy, and we've been keeping an eye on mortality in quality as well as you have been in finance. But let me just turn to the obvious area, which is emergency care. So from where I can see with all of this, we have a story each board about emergency care. It's clearly under a very challenged situation. The numbers are really, really poor. The numbers we've got, of course, only go to a certain point, so they may be improving now. And I can see what you're doing. You've got a sort of set of things that you are doing. People are coming in, etc. But for this coming year, we've got to try and reach 76% to be compliant with 4 hours, which feels from where we are today in this particular report like an absolute Everest to climb. And I would find it really helpful, a couple of things really. One is to have a sort of collated collection of things that you're going to do. So describing in one place, what are you going to do that you believe is going to make the difference? And how much impact do you think each of these things will have? And how do we have some sort of trajectory of actual improvement? So I'm thinking of this from the point of view of a patient. These are numbers, but this story of where it is at the moment in terms of going through the system cannot be good. I mean, I know there's great stuff going on, and I know Catherine's done many things in Manchester as well to try and keep safe under the current circumstances. But I'd like to think we could move from, sort of shaking our heads in gloom over it to actually where have we got to, by when, and can we as a board hold ourselves to account for that delivery? Which I'm sorry if it sounds a bit spiky, but I just think we've got to get out of this space of just looking at the miserable figures.
Yes, with the same point.
Okay,
But it's worth you don't have to answer twice.
So and what I would say, it is miserable looking at the figures, but I don't think we're taking that sort of approach to the change we're trying to make within the site. And we have in the last year tried a number of things, working with NHSE regionally as well, to learn from best practice elsewhere about some of the initiatives we've done. So the continuous flow model we implemented that showed some positive signs from Bristol and various other bits and pieces of work we're trying to do around it. I think what we're really getting down to at the minute is some real clarity about where the worst blockages are in the system. And I've talked before about the external blockages, but there's also some really significant internal blockages as well. Some of it's about where the right decisions are made. And I think we have added a lot of clinical staff into the pathway. I think what they're predominantly doing is caring for patients in blockages rather than removing the blockages and encouraging flow through the system, actually. So it's not so much about the clinical component of the care, it's actually the management of the pathways where I think we need to think about some more focus, actually. And that will, one of the tasks on the agenda for Louise at King George and for the site team here is I think we need to start with a blank sheet of paper around some of our site management approaches, because layers have been added to it over COVID, etc. Lots of that needs stripping away back to a real clear basic focus on good practice around flow and operational management of the organisation. The part of the structural change we've done is designed to really emphasise that. The previous structure we had here allowed no sense of accountability around flow and the interactions between different parts of the new services. The new structure gives that clear accountability and that understanding of that. The other thing in the context of the 76% is the activity that BHRET provides here accounts for around a third to 40% of the overall performance of the trust against the all-type scores. So we report the lowest amount of our activity as type 1 in London. And actually, so the majority of our performance is reported through PELC, through type 3. So when you look at 76%, that's an average of our performance and PELC's performance as well. And so there's a significant part of that ground can actually be made up by PELC's performance. And so PELC's performance in January, for example, had been at the level it was last January. I think we'd have been at the bottom 5 trusts in London for all type performance. But because it's declined alongside, our type 1's also, I'm not defending our type 1, which is extremely poor. But it's really important that we work in partnership with them, because the majority of our emergency patients on this site are seen by another provider. So part of our success is depending on that. The other part of it is dependent on us really making some serious inroads into this flow challenge. So I should say the mental health, I think in February, the initial data looks like we saw some quite marked improvements in February. And if we get 2 or 3 months of that, then we'll have a trend.
So if I can just come back very quickly, so I don't disagree with you about the health and the importance of bringing the type 3s in, but I'm thinking about this from purely the perspective of being a patient and going through. So when we now have nobody in corridors, we have people moving through smoothly. That I think is kind of bigger than the numbers, but they do reflect crowding.
We've been focusing on performance as a function of better flow predominantly, but the corridor care has become a really, really difficult thing to shift. And it's predominantly frailty patients as well, many of whom I think would be much better cared for somewhere else.
I suppose it was sort of almost following on from Kathy, because when you look at these graphs, clearly we're so far away from where we need to be, and we're so far away from where we need to be next year in terms of the target. And I understand everything you're saying, but in terms of, for me, for a kind of assurance, are there steps, you know, would you expect us to be at this level by April, this level by May, that level? Because it just feels to me as though we're where we are now, and at some point, if all of this works, we'll be here. But it just seems such a big jump. So are there some sort of intermediary steps that mean that we would know if we're inching or more quickly towards where we need to be? Because I believe you and I understand everything you say, but
you want to see evidence.
But there's a big leap, and I can't see what the steps are that we need to hit to mean that we're going to get 76. I suppose that's my.
We can quantify that and break it down by non-admitted patients.
Yeah.
Patients where we need to see those changes.
And I see your help and non-help bit, but you know, if I understood where some of those figures were, I'd know if we were doing our bit or help. See what I mean?
Broadly speaking, we need to get our type 1 performance into the mid-40s, and for us to have a chance, I think, as an organisation, hitting 76%. So that, for me, would be our goal. The January figures, I think, you know, there's an uptick in January. It's one data point. The whole country saw a positive blip in January. It's dropped back down again in February. So I think set aside that January number. We know things will get better. It's whether they get better than last year and whether they're taking us on that trajectory to where we need to be, which is mid-40s.
But it would help.
We can
to
present
know what the
that to you.
trajectory is. So we're measuring ourselves against the trajectory rather than measuring ourselves against.
We do have in our software reports on that.
The other very quick point I got was a lot of our challenge is around other parts of the system, and particularly like discharges on other parts of the system. And I know we're working with the ICS locally to try and do what we can with our local authority partners. One of the issues that came up on our walk around this morning was actually Essex. So although we've got pretty good relationships with our own ICS where we've sat around the table, what's it like with Essex, and what are we able to do about being able to discharge people and work with people in Essex, which is a whole different area?
I think just 2 other things.
Sorry. Does anyone want to respond on Essex? Because next it's Marta. Were you going to respond on
I was
Essex?
just going to say something about
Well,
Essex.
you say Essex and then
So
we'll
as a
go to
live
Marta.
example, yesterday we had 4 patients that have been waiting for well over a week to go back to Essex Trusts as repatriations. I think the answer is that the Essex relationship doesn't work unless it's escalated to a very senior level. So the bit that we need to do is to go backwards on that and start to make normal escalation between, you know, operational teams work and work properly for them. Because what we can't do is rely on a coup, bringing a coup just to get a patient out of hospital. So you're right, and that's an area where we've got to get better at sharing responsibility for urgent pathways. That's right.
I think the point I was going to is covered, because I haven't seen people saying where we are now. I know where we need to get to, but I've not seen a progress from the charts we have. It's difficult to understand how we want to progress, as opposed to know where we need to get to.
So
Thank you. 2 points from me. One is to say that the work that we're trying to do on the BAF around trajectories of improvement absolutely ties into this conversation. We say where we're going to get to, but we don't actually say what our milestones are. So I think if we can join the dots on that, that would be a very coherent way of us having this conversation. And then my second point relates to flow and the visit that Jackie and I did earlier. And I think what we're doing is sort of working our way down the hierarchy of levers to pull and things to change. And I think we're getting to a point where some of the building blocks of our flow are about how we handle our ward rounds and how we prioritise the minutiae of discharging people at pace. We had some really interesting conversations with the matron and the team about, well, if we just restructured the ward round a bit, we could get people out faster. So I guess it's a question probably for Mamta about, is there a way of us facilitating that at pace, because it felt like it was in our gift to make those changes and it would improve flow and help at the front door. Sorry.
So mine might add on to that a little.
Okay.
So just thinking about the junior strike coming up, which I think will be a shock to the system, to say the least, but actually also an amazing opportunity to relook at how our workforce can change pathways if sometimes a senior person is in decision-making stations, to allow some movement. Have we got in place a decision to audit that maybe on one pathway, so maybe just looking at frailty, because that could really shape how we do our workforce onwards. I mean, at the moment, we are very reliant on our junior doctors doing a lot of the discharge summaries. Does that really need to be a junior doctor? How does that impact their training? Because frankly, it's a rubbish thing to do as a junior doctor. And I think they're pulled in lots of, they will always put that down as a lower priority because they've got a sick person in front of them, which is actually where they need to be, not doing a discharge summary. So it's, I just feel like this is a real gift coming our way to do a really good piece of work, but it needs a bit of planning now, if that hasn't already gone into place before it comes. But it kind of comes in with your point of, if we're going to restructure something, we've got to have something behind it to know why we've done that.
I like Matthew's point about stripping back the decision making, the governance back to basics, and making it simpler about who's accountable for what and how we get patients through, and pushing patients along, better outcome for patients as well. And it's, I think it's good that we do have some milestones, and we'll get some milestones around it. It'd be good to put some financial milestones around that as well, because the faster patients go through, the less staff we have looking after them as they're log jammed through the system, and it means we've got a fighting chance to hit the off-framework target we've got in reducing agencies. So staff are going to have a better outcome, patients are going to feel that they're treated quicker, and it does help significantly the money issue as well. So some challenge on milestones, I think it's a really good one. We had, and we will have a PMO set up, a program around it, and we'll have that reporting. But we currently don't have that clarity of that oversight and transparency around some of these things.
Caroline? I was reflecting on what you said, Fiona, about the elective aspect of patient pathways. And I was wondering, how will we ensure that health inequalities are improved and certainly don't get worse as part of that?
You mean in terms of the waiting list management?
Well, you were saying about having the opportunity to book and take control of their pathways, but there will be different people with different levels of capability, understanding, or ability to do that.
Sorry,
yeah. So could you say a bit more about that in relation to the inequality aspect?
Yeah. So I mean, outpatient transformation is basically unpicking what we normally do, which is see people in the hospital and offer them different ways of interacting with the hospital. The patients that we work with are all patients, but obviously all of those opportunities are nuanced depending on the background of the patient, even things like first language spoken, everything can be bespoke to a scenario for a patient. So in terms of safety netting, what's most important is that we don't implement things and disadvantage communities by implementing them in a way that doesn't suit them. So just to give you some assurance, I can't talk about a specific area, but and we did talk about the learning disabilities part of the PTO last time at the private board. What we do though is we create a new initiative, but there's a safety net for everything. So if it doesn't suit people, or for example, technology doesn't suit everybody, certainly the older generation don't necessarily want to an app.
Don't make a sweeping statement.
Okay.
Because it's not my experience of myself or my mother.
That's right, but equally there are some young people and some old people who don't want to book their outpatient appointment on an app, and some do.
You can't tell.
So what you do is you have to continue to offer both opportunities to people. So from an inequality perspective, the commitment is that we bespoke everything we do, and we nuance and test it to make sure that it doesn't disadvantage groups of individuals or individuals in their own right.
Thank you.
Thanks.
Okay, good discussion, but I think that started and it was reiterated during the discussion from a view from the board that it would be helpful to have something to benchmark our future progress as well as record our where we come from. So perhaps if people could give a bit of thought to how that could be presented to the board in future, that would be helpful. Thank you. Finance report.
Yeah, so thank you. So the paper you've got takes us through to the end of January, and our performance to that point was that we were 20.5 million off of plan, which is actually on trajectory to deliver our 15 million of forecast, as Nabu said. So we're working up to 24 million by month 12, and then that will come down through 9 million of non-recurrent back to 15. 3 million of that non-recurrent is cash supported, 6 million is not. And I'll talk about cash in a minute. We have seen some general run rate improvement through the year. The elective improvement that we've just heard about has been sustained. We've seen our activity increase. We've seen some good progress on some areas of temporary staffing rates. We've got our framework challenge that we know about. In terms of the impact on cash, we began the year at about 45 million-ish in the bank, and we're down to 14, so a significant reduction. 15 because we're off plan, and 15 because we've got non-recurrent, non-cash back things in the position. Now that will be okay and see us through to the end of the year in terms of being able to pay people on time. We've talked to the ICS and they will advance payment. So we normally receive payment equally every month. They will change that profile to help offset our PFI payment, which is significant and make that cash outgoing lumpy. So that will mitigate that issue, but we will have to flag during the planning round that we've got a cash need, and that cash need will come at cost. At the moment, probably between £2 and £3 million of additional cost related to borrowing cash. So deficit comes with a real issue. We are one of the 2 or 3 lowest cash holding trusts in London. So we do need to do our best across North East London to try and get cash in the right place, or the mechanisms don't necessarily help with that. And then just on capital, it's typical year-end capital stuff at the moment, trying to land a position tricky. 2 separate pots. One is the North East London the North East London allocation. We'll probably get close to spending that. Then there's the national capital money, things like CDCs. We will probably underspend against that, but there is conversation of national drivers for that, supply chains, long approvals, and we therefore expect that there will be a mechanism to sort that out next year. That's probably the summary. You've heard quite a lot from Mahbub, but I have to take questions.
I would have put cash. I'm very worried about the cash position. I would have had it in red rather than amber, I have to say, and I'm no less worried by the idea that our solution is going to cost us a lot of money to borrow. If we can find a way through the ICS to mitigate this year's, why can we not, if we really are operating the system, find a cheaper way to mitigate it ongoing? Shane?
Yeah, so same point. You know, as a point of principle, there probably is enough cash in North East London to handle this and avoid ridiculous borrowing costs that are just money we can't spend on patients. So I just want to encourage you guys to keep that dialogue going with the CFO from the ICS, plus the other CFOs. I suspect there probably is some solutions we can come to.
Kathy. Exact same point. I was circled the cash bit in red on mine. But my point was there's a slide further on around in the appendices, I think, around the divisional or the different departments positions, all of which seem a bit different, but some are kind of more red than others. But my question really is, and it was touched on sort of earlier, is how well engaged are the teams in all of the areas to actually, you know, try and tackle this and help for the future on the financial position? Are they thoroughly engaged, or is it like a foreign language? Or
I'm going to give it a go. I think there is unwarranted variation. So we do have some good, actually. The elective is good, women's and children is good, but it is the UEC pathway, particularly with the reorganisation being in progress, where we've got the biggest challenge. So new people coming in will be very helpful.
And I suppose I'm thinking as well, not just the people you'd expect to be dealing with finance, but the clinical people and the people who actually spend the money. I remember Helen Bevan once said it, 70% of the spend cost is the pen of a doctor or something. You know, it's that sort of prescribing activity. Are they bought into reducing waste and helping with pathways improvements, really? Because that can be really key.
Would you mind if Mike and Manta answer some of that? So you observe consultants as well.
I would say, Kathy, no. I don't think there are some consultants who are very switched on to the money and the whole cost of a pathway for a patient, to the NHS for a patient. And then there are some that are completely oblivious to, and Matthew ran a job planning session actually for our consultant now, because, you know, we were trying to get people to understand the value of the money that we're giving, the salary and what that means for patient care. And I would say it is very good. So Janine and I at King's Fund yesterday putting together a clinical leaders program. We think we need a core function of what are the core skills you need to be a clinical lead. Finance is a big part of that, because we kind of devolve the medical bit from the finance bit. The doctors are responsible for a huge amount of spend. So we will, the offer will be to you, sponsor a session, understanding not just how money flows from the Department of Health to the patient, but also our role in, you know, cost improvement, using of equipment, and just kind of things that are small in, may not be very big individually, but collectively will be a huge. So we're on that.
Yeah. I mean, just tell you a small, probably now rather amusing story, but when I was a consultant, I was kind of, you know, something wrong with me, but I was obsessed with this sort of stuff. And I had
you've ended up making
I got them to tell me the cost of, you know, blood tests and everything. And I had it on the trolley thing. So whenever they'd ordered things, I'd just go, oh yes, it was like, and it did make them think, and it's a simple, anyway.
There is an issue, there's exactly an issue of accountability in the way in which you outline, Kathy. And we should do it as part of the consultants induction if we don't already do it. You have an accountability as much as any other person in the trust for the finances of the trust and for your own spending. Sorry.
Well, we've been looking hard at the waste actually around clinical equipment, medications, etc. Actually, and it was we had a really interesting discussion with some of our shadow exec team who more clinical front line stuff and look at the exec papers, and they had a look at the waste reduction paper we brought to last month, and they were coming up with some really practical examples of things where some of them knew the cost of the equipment they were using, but recognised that the clinical teams didn't, and they were providing examples of it. Someone just by opening something up and then not deciding to use it in the course of the procedure might have written off 300 or 400 quid. You know, or someone who takes a pack of things and takes 2 things out of the pack, the whole pack then has a lifetime on it. Prescribing decisions. Some of the prescribing decisions we're making on discharge, just in anticipation of it taking a number of weeks before things are picked community, you know, and there's all these examples around drugs and that where, and we don't sometimes help the staff because we make the spend or the costs associated with the decisions very opaque. And it's interesting, you know, obviously that some of our staff work in private environments as well, and you often find that in their private environments they understand the value of every single thing they are using. And they come in here and we make it very, very hard for them sometimes to realise that. And some of the developments we're bringing around Omnicell and others are really happiness control stuff like that. There's big
Maboob, and then. Oh, sorry.
I'll just move.
Shall I sort your cushion out?
Yeah, I mean, sorry. So I guess the point I wanted to emphasise was on that, on two things. First of all, the cash position, because I raised it as a risk in Chair's report. One of the reasons why it's amber here is that the ICS do attend our meeting, and their finance person comes along and they hear what we say. And for the last few meetings, we've been talking about the cash position, and they've been making positive sounds and stuff. But I guess we shouldn't change it to amber until there's actually a plan in place and we know where the money's coming from and that there's that. Because we're not the only big organisation that's going to have significant issues with financially challenged for next year as well. So that's a real helpful sort of point to get that deal done. We can call it a deal as quickly as possible. So that's sorted out. The other thing is just to say about the culture. The culture is a real difficult one to crack, because if you think about it, people believe it's the HR's department to sort out culture in the organisation and to tackle all the issues that we know that exist that cause issues. They think it's finance's responsibility to make sure that we reach financial balance and not individual responsibilities. So any ideas, any suggestions helpful. I mean, Shane was saying that on the inside of drugs cabinet, they have a price list of what things cost.
Yeah.
Because at the end of the day, it is public money, it's taxpayers' money. It's not trust money that comes from somewhere, and people pay their taxes, so we get great services. But there might be, you know, other ideas that primary care use around, you know, driving financial value into an organisation.
Catherine, and then
Thank you. Recognising that board managers also say they've been going through really basic stuff that you would expect them to know, finance training, HR. And the sessions that have been run by Fran have been really, really well received. So people understand, because I think people get their budget sheets and think, they've spent a lot of time going through budget sheets and now understand that because they are responsible for spending very large amounts of money. So I think that I just would like to say thank you to Nick and the team who have really supported that, and it has been launched out and forward. And that will be okay.
Good. Ruth?
It's just a response to Maboob. So yes, in the community, obviously we've got this stuff, and we save millions. It is using electronic prescription service though. I mean, that is absolutely the key, because it throws up warnings and it also throws up alternatives. So it will say this will cost this, but actually if you considered this, because it's the same product, but it will cost you a quarter of the price. And it also means those continuous audits happen. So if you get particular areas that are more expensive or a new drug that's come in, you can set that up into your alerts. We also have in primary care, for every prescription that we do, it gives us a total cost at the bottom. Patients also get to see that, which I think is really important. Therefore, I don't think to do it before electronic prescription comes in would be overly fruitful. I think it would be a lot of work for not enough gain. But I would like the trust to be aware of where the trust buys particular drugs in bulk, which means you get it at a discounted price here, does not necessarily correlate into the community. And there is this mismatch of patients will come out to the community and say, well, my consultant, my specialist consultant says I must be on this. That's probably not quite what's been communicated to them. But then it's really hard to shift them to a cheaper drug, because they feel like we're battling against them and we're giving them a cheaper, inferior drug when actually we're not doing that. So it's trying to, I think, get, again, it's working as a system. We in the community have medicines management. You have medicines management here, but we're not talking to each other. So what we're finding is what happens in outpatients isn't matching what we need to do longer term in the community to save money in the system. And that is driven by the consultants making decisions in outpatients. So I think that can happen sooner, but the rest of it, I would encourage you to wait till electronic prescribing and alert systems are there.
Caroline?
I'd like to pick up on Ruth's point actually. I think that there's something, and you get this particularly in general practice, but elsewhere, and I experienced it, whips up all shame, the wonderful experience I had with the fantastic consultant there, who spent an extra 3 minutes with me, but it will in perpetuity save the NHS hundreds, if not thousands of pounds in medication by that extra conversation. So perhaps that's something when you're thinking about the leadership training as well, that different way of thinking of things, because that 3 minutes made all the difference to me.
Okay, good. It will be interesting to hear the progress that we make on finding cheap cash. I look forward to having that reported back to a future.
That's finance's job.
Right, Audit and Risk Assurance Committee report. Sue?
Thank you, Jackie. So I've just noticed the dates are transposed in the very first paragraph of this. We met as an audit committee on the 4th of January, and therefore I did provide a verbal report to the board on that audit committee on the 5th of January. So what you've got in writing here is actually a meeting that I've already reported on. So
Okay.
you can have the long version or the short
Let's
version.
have the short version then.
Well, the short version. The short version is I've already discussed all of the highlights of that committee, and obviously we continue to progress the charitable funds work such that we were able to come to trustee this morning. So happy to take questions.
Good, as we've done it before. Well done, Lucy, for asking any questions. Board Assurance Framework, Linda.
Thank you. Yeah, the report aims to, I've tried to set out what we've been doing since the law last met. So we've been focusing on identifying target scores for the risk areas. So we have now identified those. So the report sets out those dates and the target scores. So there's a variety of timelines there. And as Sue alluded to earlier, we're also trying to work to identify the actions that are really going to have traction. So we have in the sheet set out a number of those. There is a lot more work to do to make that clearer, I think. In committees, we've had discussions around those controls that are not green rated at the moment, not RAG rated. And again, that's a work in progress, really. I think there's something about how we can communicate some of that to the board without overly extending the length of this report. But it is a discussion that's held in committee. We've updated with positive assurances. We've tried to update the timescales for actions to be clear about that. I've given a flavour in section 3.1, identified what we've discussed actually within the committees, where the focus has been. So where we've got a committee that's monitoring more than one area, we're having a rolling programme and trying to dive into a number of those across the months. The report also includes a snapshot summary of the scores on the 5x5 risk matrix, which shows that workforce at the moment looks the highest risk area, and UEC and the safety risk is the high scoring risk, along with finance. Bulk of the report is a snapshot summary, so we try to give a flavour of the summary of position for each of those risk areas and some key points. Next steps will be to create the BAF for the new financial year. Board agreed at the previous meeting to roll the objectives forward. We'll update the metrics that sit with that, and there'll be a new risk in relation to health inequality drawn up ready for approval by the board. I think we should standardise some of the reporting that we put in the committee assurance reports score, so the board sees consistent format in the reports that you press. I'm talking about what we discussed in committees on the back that standardise. It's an iterative process with the framework. We're continually monitoring it and improving it. Audit committee will receive a report next week on the internal audit on the audit assurance framework, and that will have some recommendations for some improvements and best practice to move it forward again. I think the key piece that we must do next is the risk appetite, and really I'll just keep working with exec colleagues. We just keep trying to improve the reports, make them clearer, identify how we can best summarise this for the board. In terms of the detail of the risks, that's all within the framework. Risk there is on the detail of that. We will reflect in the updated risk strategy changes to process around this work. So that's sort of the flavour of everything. Just trying to sort of write a report that is digestible in the board, really is the focus. Questions?
So thank you. I mean, I honestly think BAFs are very tricky. So I just say that. I just think that see far too much. I've got them in my dreams, I think. Just a couple of comments. One, and it's probably the answer is probably going to be this comes into the risk appetite. But on particularly say looking for quality targets, they seem quite high in terms of quality and safety. And if the answer is actually we'll have a longer term where we have an appetite that we're trying to get into, and this is a realistic trajectory, I quite accept that. The other, what was my other point? So that was, oh yeah, the other point was that our timing, the target dates are all different for the different risks. And I just wondered if that was deliberate because they're on different trajectories, or whether or not we should actually set a single date and say, well, we'll get to by then, and then have another date when we hope to get to by. Those are just questions really, but otherwise, you know, I think it's tricky, and you're doing a grand job on it, to be honest. It's very difficult.
Yeah. So absolutely should link to risk appetite. It's critical that we do that piece of work next, because that will reflect what we put within this. In terms of
So I think what Kathy was asking was, is it because of risk appetite that it is as it is, not, and the answer is therefore no, because we haven't done the risk appetite.
Yes. Thank you. And in terms of target dates, yes, they are all different. So that's the result of different conversations with exec leads that we have set different timelines deliberately. Historically, we've always done like a 1 year BAF, and we kept saying, well, actually, the likelihood of shifting any of these will be a longer period. Yeah. So whether there should be a single date, I think we need to give some thought to that, but colleagues' views.
Yeah, Kathy, I would actually say it's a bit like the discussion we were having earlier about understanding the trajectory. And I would suggest it would be unwise to set the same date for everything, because it depends on the mitigating actions and how long it would take for those mitigating actions to deliver, and that's the date at which you need to set your time.
No, I don't disagree. I just wanted to check that this was a deliberate for that reason. And actually, one of the criticisms very often of that is that 1 year, and actually you haven't got a snowball's chance of getting there. And actually, what you're better to do is just a realistic thing. But then I think there is as long as the reports come back to us with that sense, if you're trying to get there, you've got this far so far, and then we as a board and audit committee so can say, I think you just need to do more mitigation if you're not getting there.
Okay, good, thank you. Risks identified during the meeting, it feels as if the things that we have most focused on during the meeting are those things that are highest risks. Is there anything else that people think has changed that analysis that we've been talking about? No, okay, good. Is there any other business? Okay, you can tell me what you think about the meeting offline. Questions from the public, Andy?
Thanks very much, Chair. I welcome the good news about the new unit on the King George site. Sometimes these things are delayed. Could I have an update about are things on target, and if it is delivered on target, the expected reduction from your very poor Type 1 A&E results, please?
I mean, the new building at King George is 2 additional theatres, so 2 additional surgical theatres there. So that will enable us to put on additional surgical lists during the week, and it will be as part of the elective hub there. So the surgical hub that I talked about earlier. The building work is on time, so far I'm looking for spring next year to get that open and running, and that's going to offer us some real enhancements to the amount of care we can provide there. It won't affect the Type 1 performance because it's not directly related to the emergency pathway. So there's no inpatient beds there, there's no overnight beds there. It's a couple of elective theatres that help us with that. So it's a great thing for the King George site. The only possible benefit to the Type 1 performance is that we know that a significant number of the people that do come through A&E for emergency surgery are already on our surgical waiting lists. So the more people that we can get through their planned care in time, that in theory takes a bit of pressure off the front door, but it's quite hard to prove a direct link to that. So I'm not going to claim any benefit from Type 1 off the bat. But the project as a piece of building for 2 theatres is on track and should be open next spring.
Great, thank you very much for that.
Is that it, Andy? Okay, good, thank you. That brings us to the end of the part 1 board then. Given that it's 2:26 and everybody's here, could we start part 2 at 3 o'clock rather than 3:15? Thank you. Good.